I'm doing well, brother. And you?
I'm doing great. Thanks for having me on, Doc.
Not a problem at all. As I was saying to you before, anytime I see somebody who, I spend a lot of time on social media, and anytime I see stuff that's interesting or I think that's worthwhile to patients, I like to connect with that and I like to promote that. And something that you posted the other day really got my attention as an orthopedic surgeon, and because a lot of people asked me about this, and I thought I got to talk to this guy and see what he's all about. So first of all, thank you very much for doing it. And without any further ado, let's get right to it. So first of all, before I start asking my questions, please tell everybody a little bit just about who you are and what it is that you do.
Yeah, thanks for having me on. I really appreciate it. My name is Marc Surdyka. I'm a physical therapist who practices out of Los Angeles, California. I also teach at the University of Southern California in their Doctor of Physical Therapy program. And then I have some online businesses as well, E3 Rehab. And that's me. Yeah.
That's you in a nutshell. All
In a
right.
nutshell.
Perfect. Perfect. All right. So I want to get back to talking about your post, but first thing the first question I'm going to ask you about. Obviously, when I go through your feed, strength training seems to be a large part of your practice. My first question to you is, why the love of strength training, and why do you find it's an integral part of your practice, if in fact that it is?
Yeah, it is. It's part of, right, my own personal practice, but also my practice with patients, with clients. For myself, it really grounds me, right? It's kind of that anchor that I can always come back to. It's a nice stress reliever, and it just has, a plethora of positive benefits, whether it's for muscle mass, bone health, bone density, heart health, just everything that you can think of. And from a patient perspective, we'll talk about this some more as well. But as a physical therapist, I'm not only addressing a person's pain, we're trying to improve their function, their performance, and think about their, longevity and lifelong health. And strength training, can do all of that stuff. And it's so adaptable, it's so scalable. Sometimes maybe competitive sports or these other activities, people feel like they're out of reach. But with strength training, you can come, and if you can only deadlift 10 pounds, that's fantastic. Let's start with 10 pounds. I don't care if it's 10 pounds, 5 pounds. There is always a starting point, and a place that we can build from. And that's why I love strength training so much.
Okay. And is strength, like, when did you discover strength training, you personally? Not for your patients, but when did you discover strength training?
Yeah, so I grew up a competitive athlete, mostly wrestling. So my dad was taking us to wrestling tournaments probably when I was 5 or 6, driving to different states. And so probably around sixth, seventh grade, my version of strength training was doing some pull-ups, push-ups, maybe some lunges and squats. So it started there. And then I think in high school, and we'll talk about, what about my feed grabbed your attention, but in high school is when I switched from competitive sports to really integrating strength training into my life. And that kind of became my new thing that I attached to.
Okay, excellent, excellent. Okay, so now let's talk about what it is that drew my attention to you. Okay, so in your feed, you posted a picture of yourself, and you told me that this is actually your implant over top of your legs. Okay, so first of all, I have to say that your legs are like, they're huge, which is awesome. I'm a gym rat myself, so I always like to see that. But you posted a picture of your total hip arthroplasty over top of that. And so that got my attention. So what I want to know is, first of all, it appears that you had your total arthroplasty very young. And then not to say that you're baby face or anything like that, but you are a young man. And so definitely younger than we would expect to have a total hip arthroplasty. So why is it that you required a hip arthroplasty at such a young age?
Yeah, so it's a long story that I'll make short. So I was diagnosed with acute lymphoblastic leukemia at the age of 15. So cancer, right, for some of the listeners there. I had to undergo treatment for 3 years. And along with, 3 years of chemotherapy, you're under high doses of prednisone, or, these steroids. And so if you look at the literature, right, there's this correlation between these high doses of steroids and potentially this condition known as, osteonecrosis or avascular necrosis, which is what I developed of both hips, actually. The right hip was more severe than the left. So I think, they discovered that I had this avascular necrosis when I was probably 17 or so. And I kind of dealt with it. Obviously the doctor was saying, you just got to try to live with it for as long as possible. So I had that for about 2 years. So freshman year of college started getting really bad, to the point where I went to Arizona State. It's a big campus, doing a lot of walking. It was very, very hard just to walk from class to class, hard to do my activities of daily living. And so finally, between my freshman and sophomore year, during that summer, I decided to go ahead with the surgery. And it's not a decision that I take lightly, right? You get some comments where people say, well, did you try this, or did you try this conservative management? Of course. I wanted nothing more than to not have my, hip replaced at the age of 19. But it was something where I couldn't function anymore. And the pain was just too unbearable. And so I'm 30 years old now. I'm almost 31. So I've had the total hip arthroplasty for 11 years now.
Okay. Well, certainly, the one thing about that is, with your particular case, the avascular necrosis was when I saw the X-ray of your hip, and you had said in the post, yeah, this is my actual hip. You had lost the shape of the femoral head, right? And so basically, you have a square peg in a round hole. And man, I don't care. I'm a sports surgeon, so I try to have people maintain their own joints for as long as possible. But I do joint replacements, and at some point, as like a square peg in a round hole, there's no amount of physiotherapy, there's no amount of injections, there's no, that's a mechanical issue. There's no amount of anything non-surgical that's going to make that better or feel good, right? It's just a mechanical thing. So let's go to the next question there. Now, you obviously, so it's interesting that you have an arthroplasty. But what I found even more interesting is that look at the legs that you have after you have this arthroplasty. And so for me, that's really cool. Okay, it looks like you have been very successful in your ability to maintain your physique and your muscle mass in your legs, despite the fact that you have an arthroplasty. So my first question with that is, how have you been able to do that?
It's been a lot of trial and error. I'm not going to lie. It's you don't just develop an understanding of how it's going to feel or how you're going to move after this, at the age of 19. And so there was a lot of experimentation because, I didn't have a normal kind of high school life with having cancer for 3 years. And, I had to give up competitive sports. So I still wanted to be competitive, right? I didn't play at that same level, but I played some intramural sports. I played some, sports with my friends. I've done a lot of different things in the weight room, outside of the weight room. And not all of those have felt great. I'll be honest. And some of those things I probably maybe shouldn't have done from, just the joint perspective, but for my own mental health, those are things that I needed to do. And with that time and kind of with that experimentation, I have found what works for me that also doesn't necessarily, aggravate the hip. So my goal isn't to, let's just push as hard as I can. And if my hip flares up, it flares up. It's, how can I modify certain exercises to meet my needs rather than, fitting myself into certain exercises. So for example, squats. Squats, for the most part, require a pretty significant amount of hip flexion if you're trying to get to that parallel position. Well, I prefer to do split squats. So it's kind of this static lunge position where you're just going up and down. And the reason being is that I can change my torso position, be more upright, training similar muscles, but I'm not in that deep hip flexion that's provocative for me, right? And then I can also utilize machines. Sometimes machines get a bad rap, but I can do leg extensions and hamstring curls and these other machines that really give a good stimulus to the legs without, same thing, provoking my hip. So the two things that might provoke it would either be, just from a weight training perspective, I guess, would either be kind of deep hip flexion, and then maybe a lot of compression, right? If I'm holding a lot of weight, that might do it. So I try to find that nice balance of, how can I stimulate the muscles a lot without provoking the hip? And I'm not going to say that it's always perfect. There are times where it gets a little bit irritated, but there's times when I don't do anything and I'm just, driving on a road trip and my hip gets irritated. So, I'm not too fearful of some of the things I do.
Mm-hmm. Well, I think it's even more, now, hearing that now, I think that's even more amazing that to know that squats, the prototypical squat, is not necessarily the main component, and you have legs like that. That, I think, is even more incredible, dude, because that just speaks to the amount of work that you have put in to that. So now, you spoke a little bit about this, but tell me let's go a little bit more specific about how you, well, I guess you were 17, so you were young, but how has your training changed after the arthroplasty compared to what it was like before your arthroplasty? Oh, hold on. Yeah, I kind of went out there. I'm not sure what is going on. That's... So I'll let you back in. I'm not sure what happened there.
All
Okay.
right. I
Sorry
think I'm
about that.
back. No
Okay,
problem.
yeah, you're back. Did you catch that question?
I did. Yeah.
Okay.
So, when I was 17, like before I had the hip replacement, I was still doing some stuff in the gym. Obviously, I was not nearly as knowledgeable back then as I am now about strength training and, making progress in the gym. And I kind of was that high schooler. I was doing a lot of upper body stuff, probably not, as much leg training as I should have.
Guns for the girls, baby. Guns for the
Yeah,
girls.
sun's out, guns out. And
Exactly.
then, right before I had my hip replaced, same thing. I probably really wasn't in the gym that much, just because, even if I was going to do upper body, just to pick up a dumbbell and try to walk to sit down, wasn't going to feel good. And same thing, I didn't have that knowledge to understand, okay, I can use this machine maybe to modify to fit my needs. So, a lot has changed since then, just with my knowledge of, from what I've gained as being a physical therapist, and understanding, like I said, how to adapt exercises to meet my needs rather than adapting my body to fit an exercise. And so that's been a really big change, and kind of why I put out some of this information is because I think some of these people go through these same obstacles and make the same mistakes, and I want to help them out so that they don't have to do that, right? These people get their hips, replaced, and they still want to be very active, but maybe they don't know how to do that, and they don't know how to modify their old routine. And sometimes you'll have to do that. You won't be able to do perhaps the exact same stuff that you used to, but most of the time that's fine. You can still achieve a lot of the same results, achieve a lot of your same goals, just by altering a few things.
Mm-hmm. I really, really like that a lot. In our facility, we kind of have this mantra that when we train people or when we see people post-operatively or even pre-operatively, we tell them everybody's an athlete. We treat everybody as if you are an Olympic athlete. Your sport may be just walking down the street or carrying your groceries, but we treat everybody the same. We do this similar stuff for everybody, but we modify and we scale for whatever your appropriate level is, right? And so I really like the idea of you modifying the exercises around yourself and not trying to just fit yourself into, oh, this is the way these guys do it. This is the way I saw it. I got to do it exactly that way. And you certainly have the insight to know, okay, well, yeah, I can do it this way, change my body position. I'm still attacking the appropriate muscles. So let me ask you now, what approach was used for your arthroplasty? Anterior, lateral, or posterior?
Yeah, so I had a posterior approach, and so for some of the listeners, I have a nice scar kind of along the side of my glutes. So that's the approach that I had.
Okay, and so I know what I would say, but how did that approach affect your training initially, and what restrictions did your surgeon give you?
Yeah, so after a posterior approach, a lot of surgeons do give these hip precautions. You know, one of the main ones is that you're not to kind of bend your hip more than, or your trunk or hip more than 90 degrees, right? So you keep that nice right angle. So obviously that's going to affect a lot of what you're able to do in terms of any hinging or squatting movements. So that was pretty limited. And I would actually say for the first 3 months, I didn't do very much. I had physical therapy one day in the hospital just to get me walking, navigating stairs, you know, discharge the next day. Then I had one physical therapy visit with a physical therapist in kind of my hometown. I'm from a small hometown, Yuma, Arizona. So I had one, you know, PT appointment there. But, you know, I'm pretty high level. I could do a lot of the stuff that I was given. And then probably between 3 and 6 months, I went to physical therapy at Arizona State University. And actually, it was the kind of physical therapist's assistant or person who helped him out. I think she had a master's in exercise science and a strength and conditioning coach. And she pushed me, you know, like she treated me like a 19-year-old with a hip replacement and pushed me. And so at that time, I wasn't kind of doing this bodybuilding approach that I am now. But, you know, she had me jumping and doing kind of plyometrics and different machines. And it was great. I'm like forever grateful for her because she kind of empowered me, right? She showed me what I can do. And I've kind of taken that knowledge and that experience to my own patients. So it's been great.
Okay. So obviously, as you said, your surgeon had some restrictions and you talked about posterior precautions. So now you are basically 11 years, almost 12 years down the line. You are yourself a physical therapist now. And so you have a lot more knowledge and training and personal experience, right? So how have you adapted those precautions to what you do now? Or do you just basically, as you said earlier, just modify to what works for you? Do you practice any precautions or what do you do?
So do I practice any precautions with patients that I see?
No,
or just for myself?
Just yourself.
Okay. Yeah. So so here's the other thing is the other major thing that the doctor said, right, is don't bring your knee to your opposite hip, because that's kind of like this combined motion of flexion, adduction, maybe internal rotation. That's going to put the most stress on that part of the capsule. I can't do that anyway, right? But that was one precaution. And then his other thing was, because I asked him, can I go back to lifting weights? And his recommendation was, don't lift more than 135 pounds if you're going to squat. And kind of the rationale there was that I probably weighed 140 pounds at the time. I'm only 5'7", so maybe weighed 140 pounds. I was 19. And, you know, he sees people who are 300 pounds or 400 pounds who are getting the surgery. And so, you know, they're essentially doing a squat without amount of weight every time they come up and down from a chair, the toilet, things like that. So his rationale was, this is fine. You can do that. And that was actually kind of nice to hear too. I don't know if all surgeons 11 years ago would have given that advice to a 19-year-old that probably didn't know much better, right? So that was nice for him to say. And for myself, after having learned all of these different things that I've had through experimentation, through the research, through school, I don't really put too many restrictions on what I can or cannot do. I do let pain be a guiding factor. Like I said, I've learned which movements are more uncomfortable, and I'm not going to purposely choose a movement that's more uncomfortable than another movement if I know that the other movement gives me that same benefit or outcome that I'm looking for. But I do get myself into different positions of hip external rotation, hip internal rotation, hip flexion. I've done some wrestling and some jujitsu since I've had the hip replaced. But I think
You
a lot
don't
of
have
people.
you don't have a super big rubber guard though, right?
I do not have no, not at all. And people are always concerned, like, am I going to be missing out on some range of motion? And the answer is yes. Compared to a normal, native, healthy hip, you're not going to have the same range of motion, most likely. But I have more range of motion now than I did before the surgery because of that avascular necrosis. And I also tell people that, not having that same range of motion is probably a good thing. It's going to be protective. And, I don't really have the desire to do the splits or to do these extreme ranges of motion. And it's just not necessary for 99.9% of activities that I want to do. Maybe if someone came from a background of gymnastics or yoga, they might feel limited. But for me, I don't really feel like my range of motion is stopping me from doing the things that I want to do.
Cool. Now, we talked about restrictions for yourself. What, now that you have all of this personal firsthand knowledge, right? As well as your learning as a physical therapist, what restrictions or no restrictions, what do you do with your own patients who have an arthroplasty? Because now, it's not just what you've read, what you've seen, it's also what you've lived, right? So when you're working with patients, what do you say to them?
First piece of advice, talk to your surgeon, right? Defer to your surgeon. That's a big thing, because even people will see, my story, my history, and they'll ask me what they should do. And my first piece of advice is always talk to your surgeon first. You might be able to do the same things that I'm doing, but it's nice to have that conversation with your healthcare practitioner and have them on your team. In terms of precautions, it does depend on their approach. So if someone's doing an anterior approach, perhaps there's less precautions or no precautions. If we do look to the literature, we see that there is some variability in what surgeons do recommend for that posterior approach, meaning that some don't give any precautions. Some give precautions for a short period of time. Some give precautions for a longer period of time. And there is some research that might say that in some cases that the precautions might not make a huge difference. But once again, I'm going to try to defer to the surgeon and not overstep boundaries there, and at least have a conversation with the surgeon, because maybe they saw something. Maybe I don't know the implant that they used, the other comorbidities, all of these other things. But even if let's say someone does have these precautions, like I said, I know enough now where I can work around that, right? We can do step ups, we can do step downs, we can do these machines. We can train every single muscle in the body without having to go into 90 degrees of hip flexion or internal rotation and things like that early on. And I push people, right? I want them to be pushed because it's a stable joint, right? People are walking the same day, the next day. It's incredible how successful the surgery really is.
Mm-hmm. It's interesting, I when I think about my own patients, I have precautions that I send patients home with, and they're generic precautions, and I will modify those individually if, oh geez, I think this guy's going to be unstable, or we had problems with the fixation or something. I'll modify those. But on the other hand, I'm looking for people to push themselves, and they kind of know me as the drill sergeant, because 2 hours after surgery, I'm on the phone to the floor and say, hey, by the way, did you get Mark up yet? Is he walking? Has he done the stairs yet? Right? And especially now, I was a lateral approach guy. And with my bigger, heavier patients, I still do the lateral approach, but I've switched over to the anterior approach for my low BMI patients. And that's amazing, man. To have people, they stand up after surgery, they walk, they have no limp, and they go home like 6 hours after surgery. Like, that's amazing, right? And so I'm always looking to push people. Now, let me ask you a question about something you mentioned there, because you use pain as a bit of a guide, right? So let me just ask, and this is not a trap. I'm not trying to put you on the spot. I'm just curious. I know what it means to me, but what does pain mean to you when you tell people let pain be your guide? So on a 0 to 10 scale, what is pain, and what are you talking about?
That's a great question, right? Because pain is very subjective, and the patient who comes in and says, hey, I'm in 10 out of 10 pain, and they have a pretty straight face, but to them, it's affecting their function enough, it's affecting their quality of life enough that to them it's a 10 out of 10. Or someone else, you look at maybe their image and how they're walking and how they're moving, and they say they have a 1 out of 10 pain, and it's incredible that they're functioning so well. So yeah, there are some caveats when I say pain, let pain be your guide, because we don't want people to be fearful of pain and think, okay, if you have pain, then that means tissue damage, right? So obviously this is an invasive surgery. People are going to have pain after the surgery. And so, the main thing that I'm looking for, whether it's a, total hip arthroplasty or otherwise, is, how does it feel on a day-to-day basis? How does it feel 24 hours later? Meaning that, let's say that I'm asking you to go walk for half a mile, right? And you walk for half a mile and the pain is tolerable to you, right? And this is where that subjectivity comes into play. Tolerable for one person might mean 2 out of 10 pain. Tolerable for someone else might mean 3 out of 10 pain. Tolerable for someone else might mean 4 out of 10 pain. Usually tolerable probably is going to be in that 3 out of 10 pain or less. But let's say I ask them, make sure that pain is tolerable for you. So they go on the walk, they have 3 out of 10 pain or less. The next thing I want to say is, how is it affecting the rest of your day? So you had a 3 out of 10 pain during the walk, but now afterwards you have a 7 out of 10 pain, 8 out of 10 pain, and it's affecting your ability to work, to do, house chores, things like that. To me, that's a sign of you probably did a little bit too much too soon. And that could be the case even if they went for a walk and was pain-free. Maybe they had 0 out of 10 pain, and 6 hours later, they're just incapacitated because they're in so much pain that they have to take pain medication. Well, maybe that was just a little bit too much. The other kind of things that we ask about is sleep, right? So same thing. Let's use the example, 3 out of 10 pain with walking. You're fine the rest of the day, but then at night, you're just in so much pain that you can't sleep. And then the next morning is a really good indicator too of how you're recovering. So let's say you wake up that morning. Let's say today, you woke up today and you have a 1 or 2 out of 10 pain. You do your exercises prescribed by me or prescribed by you, and tomorrow you wake up with a 6 out of 10 pain. Now, there's a lot of factors that might influence your pain, stress, sleep, so on and so forth. But for the most part, we might say, you know what we did yesterday might have been a little bit too much. So that's kind of a general framework in the sense that I'm not saying that we have to eliminate all pain or avoid all pain, but we just want to make sure that we're not pushing too quickly. And using an objective measure is helpful too. So not just thinking about pain, but if on week 1 you can walk a quarter mile and a month later you're still only able to walk a quarter mile for whatever reason, then we know that we're probably not progressing there, and we need some kind of objective data to say, okay, on August 1st, you were doing this. On September 1st, you're doing this. We can see the progress that you've made over time.
Yeah. So there's two things there. So number one, I like how you remind people we are not to be afraid of pain, right? And some people think that, oh, I got my hip replaced or I got my knee replaced, bang, no pain. And I always have to tell people, this is not the case, man. And you have to come to terms with the pain and sort of become friends with it for a period of time, right? There will be a certain amount of discomfort that is to be expected, and we have to work through it, and it's okay. But as you said, things, you can ask them all of these other questions to learn how much is it affecting their function and how long is it persisting. And I think that's important. But yes, you shouldn't be afraid of it. Right. And the other thing is, I always it is very, very subjective. And I always try to make sure that I have people speaking the same language and that I'm speaking, so that we're all on the same page and we understand this is a 0, that's a 10. And so I always kind of give people this graphic example and they think, oh, you're joking. And I'm like, no, I'm not joking. But then they kind of understand, oh, that's a 10. So I always say to people, on a scale of 0 to 10, 0 is no pain. 10 is the worst pain, where you would give me $1,000 out of your pocket to cut that extremity off with a rusty butter knife. That's a 10. And then because as you said, you got people, they come in and they say with a straight face, oh, I'm having a 10. And I'm like, no, you're not. You are not. Your 10 that you're talking about right now, that's not the 10 that I'm talking about. This is the 10 that I'm talking about. Is it that? And they go, oh, well, on that scale, it's about a 5. Okay, now we're talking the same language, right? So it is very subjective, but we always got to try and make sure that we're talking about the same thing. So let me ask you, we've talked about this a little bit already. How has your own personal experience affected your approach to your own patients?
I know not to be afraid of pushing my patients. I know what they are capable of. And I love the fact that you treat all of your patients like Olympic athletes, because I don't think an Olympic athlete is defined by a sport that they play. I think they're defined by their mindset and what they try to accomplish. And, some of the older patients, the patients actually who we'll see have this surgery more often, are the ones that benefit from pushing them the most. Like I said, in terms of that osteopenia and sarcopenia and heart health and all of these things, they're the ones that are going to benefit from that strength training. And if we treat them like they're frail or fragile,
They will be frail and fragile.
They will be frail and fragile. And, we won't be pushing them to the best of their ability. And same thing, we're not ignoring pain or throwing caution to the wind. It's a very systematic, progressive approach. But, oftentimes in typical physical therapy, typical rehab, it's, 3 sets of 10 with a yellow TheraBand, and the person does 30 reps in a row and isn't fatigued at all. And, there's no reason, if we're having a good discussion with the patient, we are defining these different terms of what's acceptable in terms of pain, perhaps. We're having a conversation with their surgeon about what's acceptable. There's no reason that we can't implement the strength training over time and teach them, if needed, how to do it on their own at home. It doesn't require a lot of equipment. And it's, like I said, it's just so versatile that there's no reason not to be doing those things.
For sure, for sure. A lot of my colleagues, where I work, often ask me, like, why would you start a physiotherapy business? And why would you have a gym in your business? Why would you do that? And when I think about it, I needed it like I needed a hole in my head. Like I didn't really need that. But just what you said there about knowing how to be able to push patients. Like I kind of got sick of sending patients out for physiotherapy and then asking them, oh, what did you guys do? And then they say, oh, well, we did the TheraBands and they gave me 3 sets of 10. And then that was it. And I'm like, okay, well, that's what you told me like a month ago. So what did you do differently now? Oh, no, I've been doing that same thing. And I'm like, you didn't like there was no progress, no progressions, no nothing. No, we're just doing the same. And it's like, that drives me absolutely bonkers, man. Because like it should always be progressive. And if I send patients out for physiotherapy, if they can't come to our particular facility or not, I'm always writing out in specific on my physiotherapy requisition: active, progressive exercise therapy. No machines, no modalities. I write those words because specifically I want them to do that. And I expect when I see the patient back, in successive visits, if I ask them what they did at 2 weeks post-op, and then I ask them at 6 weeks post-op, the answer better be something different, right? Because how are they supposed to get better, right? And people have this idea, if it doesn't hurt, I'm better. If it doesn't hurt, I'm better. But then, say for example, one of the things I do the most is ACL reconstruction. And they go, oh, my leg feels good. I don't have any pain anymore. But then when you look at them and you look at the quadricep, the bulk of the quadricep, the mass, and you look at the atrophy and you go, well, okay, I know you don't feel, I know your knee feels stable and you have no pain, but take a look at your leg, right? This leg, this one over here is a chicken leg. This one over here is a turkey leg. There's a difference. And guess what? If they were the same size before you got injured, and now one is half the size of the other, and you think you're going to go back to sports, I have another idea for you, because that's not going to happen. You need to restore this to the appropriate size, but you can't do that unless you're using progressive exercise, right? And unless you are pushing yourself. So,
Well, I think that's where the communication is so important, right? Is like you said, kind of defining those terms, having similar expectations of what this rehab is going to entail, right? That very first visit, they should know this is what we're going to do over the next month, 2 months, 3 months, 6 months, and understanding that, like you said, pain isn't always the best measure of success. There's a lot of ways that we can measure success, and maybe in the patient's mind, that is a measure of success, but that's why we have to communicate, hey, there's these other things that we can do, and that's how we can measure success as well. And understanding that, this goes back to the pain talk as well, is that anybody who pushes themselves hard in strength training, in sport, in any of those activities is going to have some pain time to time, from time to time. Like, that's a normal experience.
it's normal.
And if you're not having, these little aches and pains every once in a while, you're probably not pushing yourself hard enough.
Exactly.
And so same thing, we're being smart about it. We're not throwing caution to the wind, but we're understanding, hey, let's get them moving.
For sure. And so my next question, you basically answered it, and I was just like, has your own experience made you more aggressive in your rehabilitative approach? And I think the answer is yes. But one of the other things, though, that I want to ask you about, and I know what the answer will be. So I myself have had several orthopedic surgeries. I've had about 6 surgeries on both knees. And so I have like my, I don't want to say it's a bullshit meter, but it's like people will say things to you post-operatively. There is something to be said about having lived through it yourself, because you go, yeah, no, not quite like that. And so my question to you, so yes, your approach has helped you to push a little bit more because you have that experience. But also, have you found that it's allowed you to have more insight into what they're experiencing and what their expectations should be?
Absolutely. One of our primary objectives, I believe, as healthcare providers is building, that therapeutic alliance with the patient, having that good relationship. And so if I do get a referral from a surgeon that says, ultrasound, rest in ice, maybe things that I would deem as underloading or unnecessary, my initial reaction isn't to throw them under the bus, because that patient's going to have a good relationship with their surgeon probably. And I also want them to have a good relationship with me. But hopefully over time, if it is safe and it is comfortable, I want to have that discussion with the patient. And depending on what they want to do, I might help them come to that conclusion, on their own, meaning that, well, you want to get back to hiking. You love hiking, these 5-hour hikes, 10,000 feet elevation. What do you think is required for you to be able to do that? Is it just sitting on this recumbent bike, or do you think that, X, Y, and Z is going to help you? So, I'm not just trying to talk to the patient or educate the patient. I want to have that open communication, because, they're only going to be with me for a few months. I want to give them the tools that they can continue to utilize for the rest of their life. And like you said, you've had, 6 surgeries. Over time, things happen. This person might need another surgery. And now, hopefully, from what they've learned from me, even if they don't come back to see me, maybe they move, they have some of that knowledge and experience to say, okay, I am strong. I'm not fragile. My body can handle a lot. Let's get moving.
Mm-hmm, mm-hmm. Okay, so let me ask you, let's change gears here a little bit. So something that's very popular right now, and it's something that we do as well at our facility, is quote unquote mobility training, which kind of is an umbrella which covers a bunch of things. But what are your thoughts on mobility training, and what does this term mean to you?
Yeah, so mobility has probably taken on a lot of different definitions over time. Right? Initially, in acute care, the hospital setting, mobility might just be, how's their bed mobility, right? How are they moving around in bed? How's their mobility in terms of transfers and walking? And now I think this term mobility has taken on this meaning of maybe range of motion or active range of motion, or even some kind of flexibility. Usually for me, I think of flexibility as maybe more of like a passive approach. So just how far you can stretch, right? Whereas mobility is more of active range of motion. How far can you move into a range of motion? And I think, for mobility, it has become kind of sexy for a lot of people, but I think we have to take it into the context of the patient's goals. So you need enough mobility to accomplish the tasks or goals that you want to do, right? So, if your goal is to do the splits and you want to do the splits, that's fine. But if your goal is to, go on hikes, do a deadlift, do a squat, do a lunge, you might only need that much mobility in order to do that. So doing all this excessive work, might not be necessary. And there's always going to be a cost benefit, ratio to anything we do. If you have all the time in the world to spend in the gym and you love doing that stuff, then, go for it. But if you have 30 minutes in the gym and you have to decide between 30 minutes of mobility or 25 minutes of strength training and 5 minutes of mobility, I might put more stock and more time into that strength training. But once again, if you're a gymnast or a yogi, then, they might put a higher importance into mobility. And for me, in terms of mobility, I try to use even a very active approach for that, meaning tempo work. So we'll go back to that split squat example. Let's say somebody needs hip extension. They're lacking some hip extension. We can put them in that split squat position where that back leg is in hip extension. And then we can manipulate the length of their stance so that they're kind of, they're working into that tempo split squat, working down and working on that hip extension. Or kind of the same approach, right? We're working on an eccentric muscular contraction. So not only are we improving flexibility, but we're also improving that range of motion. So usually that's my bias. If we can check off several boxes, so we're improving their flexibility, we're improving their strength, maybe we're even reducing their risk of injury, I'm going to cater towards those kinds of exercises personally.
Mm-hmm. Okay, so let me ask you something specifically about your implant. So, I was going to ask you some stuff about your own personal mobility training, but you kind of talked about a little bit about that. Now, what do you know specifically? What type of bearing surfaces were used for yourself?
Yeah, so this was 2009,
Yeah.
right? The surgeon's thought was that, he wanted to give me as much range of motion as possible, and it was very popular at the time. So I have metal on metal.
Okay.
Now, 2 years later, if we look at a lot of, national joint registries, there's a big drop off on this metal on metal. And actually, the surgeon had to put a disclaimer video out, and the hospital system had to put this video out because the implants that they were using were recalled. And so they actually had to, do a revision on some individuals. But luckily mine's been fine. I haven't had any issues.
Do you squeak?
I don't squeak. I do not squeak.
All right.
And I know I feel good. I have maybe some other small health issues, but I think that's more related to, my past medical history, unrelated to the hip.
Yeah.
But for the most part, like I've been really happy. And same thing, I've had some people reach out to me and say, "Oh, I had metal on metal too, and I haven't read great things." And you know what? I can't complain right now. I know what the data says, but it's been feeling good. I can't change it, right? Like, I can only control what I can control. So I don't try to stress too much on, what happened 11 years ago.
Sure. Well, obviously the metal on metal had some issues, and there were recalls. A lot of people have stopped doing it, and I know in Canada most of the surgeons have stopped doing it. In the city where I live, Ottawa, there are primarily 2 surgeons that do it. They see most of the cases from across Canada, and that's just because their numbers are so high. Both of them are sort of 800 and 700 cases between them. So they still do it. But to tell you the truth, I'm 50, and if I need a hip replacement because of what I do and I'm active, I'm going to want an alternate bearing surface. And to be honest, metal on metal is going to probably give me the largest range of motion, and it's going to be the most resilient and allow me to do what I want to do. And so for myself, that would probably be my number one choice. Despite I'm an orthopedic surgeon, I know what the literature says about it, but I still would probably want that because we still are, like, those 2 guys, those 2 surgeons are still doing it for young, active people like yourself. And granted, I'm not 19 years old, but I still am fairly active. And, I think that kind of implant is going to allow me to do the things that I want to do most easily, and it's going to be the most stable for what I want to do. So to me, the disadvantages are they're rare enough that it's worth it for me to do that. So I wouldn't shy away from it. I wouldn't put it in a young female who is of childbearing age, but certainly a young male who's active, if that's what he wants. That's what I would, I wouldn't have a problem doing that, right? So
And when people ask me, that's not my role, right? So same thing. I'll say, talk to your surgeon. You can get multiple opinions from surgeons on what approach they're going to do, what implant they're going to use. I can point them in the direction of the literature and whatnot, but that's not my area of expertise. So when people ask me, I defer to you, right? Like that's kind of your role. And so I think hopefully people watching and listening understand that as well, is that you want a team. You don't just want an individual. You want a team working in your corner. So the better communication between everybody, the better off someone's going to be.
For sure. And, and patients will come to us and they'll say, "Oh, we want this," or "I want that." right? But I'll tell them, I think either yes, you should have that, or no, you shouldn't have that, and those are the reasons why. And there are times like, so for example, in Ottawa, the anterior approach is something that until very recently there weren't that many of us that were doing it. So even though we have, say 65, 70 orthopedic surgeons in the Ottawa area, there was probably less than 10 of us that were doing it. And patients would come to me specifically for that. And sometimes I would say, yeah, you know what? You're a perfect candidate for this, man. And I'm going to do it. Other times I would say, nope, even though that's what you want, you're not a good candidate for this. And sometimes patients say, if you're not going to do it, I'm going to go somewhere else. And I got to be cool with that, right? Because in my heart, I'm trying to do what I think is right for the patient. And so it may not always be exactly what they want, but most certainly it's what I think is best for them. And I think it's important, as you said, to develop a team. You want to have a team that can help you to achieve the goals that you want, right? And so everybody has to kind of be in sync and on board together. So I got two more questions for you, because Instagram will kick us off after an hour. So the next question, this is a feel-good question, but I'm pretty sure I know what you're going to say. So do you find that your life has changed significantly for the better or for the worse following your arthroplasty?
Yeah, without a doubt, for the better. Like I said, it's a really awkward thing when you're 19 and you're limping, and people, either friends, acquaintances, classmates, are asking, why are you limping, right? And I'm not the guy who's going to divulge and go through, I had cancer and I had these steroids and I had AVN. And I was really miserable at the time. And since then, it's been amazing. And, there are some things that I had to change, right? You have to cope with, I was a very good competitive wrestler, and that's just not going to be my cards anymore. And, I've come to terms with that. And I think that sometimes, patients do have to come to terms with that. But it's fine. I've shifted my mindset, and I love strength training. I love doing the activities that I do. I love to hike, so I've found other loves outside of these competitive sports. And, without a doubt, life has been better after the hip replacement.
Okay. So last question I'm going to give you is, I want to know if you have any general recommendations for active patients to consider when thinking about training and exercise following joint replacement.
Yeah, so this is a good question, because
it's a broad question, but just what are your general tips?
I think that the better they can define what they want to do and what their goals are, the easier that's going to be to figure out recommendations or advice. So once again, if your goal is just to go to the grocery store, go to work, go home, and that's it, you don't have to do too much. These are really good surgeries. Walking, getting on the bike, implementing some strength training, that's all you're going to need to do. But if your goal is to run a half marathon or run a marathon, even if your surgeon recommends against it, your mindset is, I'm going to run a marathon, at least prepare yourself to the best of your ability, and communicate that to your surgeon, communicate that to your physical therapist. Because if you have your mind set on that, and you're 19 years old, you're 20 years old, and you want to do all these things, even if they may or may not impact the longevity of your hip replacement, and all the education in the world isn't going to stop you, adequate preparation is really important. And if your goal, though, is like me, which is, I just want to hopefully have this hip replacement last as long as possible, I want to be as healthy as possible, find someone who can help you, right? Find a good physical therapist, a good doctor who's going to be your guide, who's going to facilitate that. So not that passive approach. They're not just doing things to you, but you are taking an active role in your health, in your lifestyle, you know, that is a recipe for success.
For sure, man. You can't have other people do the work. The work has to get done one way or the other, and you can't have somebody else do it for you. That's in the end, that's just the truth, man. So I actually have one other question. So, Mark, why physiotherapy, dude?
The physical therapist who I met in the hospital right after my hip replacement was amazing. So, you know, I'm 19. I'm laying in bed. I'm on, on bed orders. I'm staying in bed. I had a catheter, which is really embarrassing
For a 19-year-old?
for 19. Very embarrassing, right? And the first thing, all I wanted to do was I wanted to get up. Like, you know, why do I have to lay here? I'm healthy. I'm fine. You know, I don't think I'm going to faint. I don't think anything's going to happen. But, you know, stay in bed. You got this catheter. And then this physical therapist came through the door, huge smile on her face, really pleasant. I wish I knew her name. I always say this. I wish I knew her name. I wish I could thank her. But, you know, she made me feel like the most special person in the world. So to go from feeling, you know, disabled to walking and doing stairs and feel like you have your life back, it's a really amazing feeling.
All right, giddy up, man. So, like, I think that's an amazing experience, and it's an amazing story. And I have to say, once again, thank you very much for being on here. But more importantly than that, the story, your own personal story that you shared, and your experiences, like, you didn't have to do that, and you've opened up to us, and you've opened up to me, and you've shared that with us. So I have to thank you very much for that. I think it's like extremely educational for people who are going to view this. But again, I have to say thank you, because, you know, you could have kept all of that stuff to yourself and just, you know, kept it very generic. But thank you very much for sharing that. Now listen. So yeah, Instagram is going to kick us off in a minute or two here. Well, first of all, let me ask you. Well, this was awesome. So I'm going to probably want to do this again with you. Pick your brain on some specific topics other than arthroplasty in the future, because I like your active approach. But for everybody else who's watching or who's listening to this, dude, tell them where they can find you. And you got a minute and a half to do it, because I see the timer at the top of the screen. Go.
So find me on Instagram here, dr.surdykapt. And like you said, I post a lot of, you know, kind of active approaches to rehab. I also post a lot of kind of myth busting videos. And then I have an online educational platform with 2 other physical therapists called E3 Rehab. And so that E3 stands for Empowerment Through Evidence-Based Education. So our goal, really, like I said, is to empower others. I think sometimes in our healthcare model, we don't always get that empowerment. And it sounds like what you're doing, right, is empowering others. And that's what we want to do. And we want to give the people the tools to do that. So we have blogs, we have a podcast, we have YouTube videos. And I have 2 YouTube videos actually where I talk about all this. So I talk about my experience having the hip replacement, and then I talk about strategies for exercise that you can do anywhere between months, you know, 1 to 6 to build up your strength and improve your function. I have a long blog. I think it's like 9,000 words on the website too, e3rehab.com. And it just outlines a lot of stuff. It outlines my experience. And so if you want to learn more about me or, you know, this surgery, you can go there and check it out.
Perfect. Thank you very much. That's perfect timing. So hey, you stay on Zoom, and I'll chat with you after. But for everybody who came out to participate and to listen to us, thank you very much. We'll be back again next week with another speaker, so don't miss that. And as always, that's been a word from Dr. Chris, not your everyday ortho. Peace out, everybody.